Hello friends, so what do you see in front of you? Yes, you see the posterior view of a person's thoracic region, and you see the position of some leads named V7, V8 and V9, and you might be wondering what they are, because what you know classically is V1 to V6. But those of you who know what V7, V8 and V9 mean, you might also be knowing where they are placed. And if you read the question carefully, you might also be able to arrive at a diagnosis. So what does the question read? The given leads are useful in determining infarcts associated with the right main coronary artery, the posterior interventricular artery, the left circumflex coronary artery and the left internal thoracic artery. Even before we start explaining this question, you should be able to understand one thing, that in ECG we mainly deal with the pathologies of the coronary artery, and as you know, the left internal thoracic artery or any internal thoracic artery for that matter is not directly related to any of the coronary arteries. So possibly one option you can exclude even before I start explaining, and even before you get a solid concept about this, is the internal thoracic artery. So it is a fight between A, B and C right now, right? So that's how you do questions. Just to give you a preliminary idea about the lead placements of the chest electrodes, if you consider this to be the sternum diagrammatically and you consider these to be the ribs on the anterior chest wall of a person and you number them, you know that the lead V1 will be placed on the right side parasternally in the fourth intercostal space, V2 on the left side parasternally in the fourth intercostal space, the lead V4 along the left midclavicular line in the left fifth intercostal space, the lead V3 in between V2 and V4. The lead V5 and lead V6 will be placed along the same line as V4, I mean the horizontal level, that is the left fifth intercostal space, V5 in the anterior axillary line and V6 in the mid axillary line. What about V7, V8 and V9? V7 would be in the left fifth intercostal space along the posterior axillary line, that means the posterior axillary fold. V8 just below the angle of the left scapula, inferior angle of the left scapula, and V9 would also be along the same plane as the left fifth intercostal space, but it would be along the paravertebral line on the left side, right? So those would be the lead placements that we were talking about. V7 you see along the posterior axillary fold, posterior axillary line, V8 just below the inferior angle of the left scapula, and V9 along the left paravertebral line. Good. Now the question has asked you about which of the following arteries might have been affected, or a pathology of which of the following arteries has been indicated by the following leads. Infarcts associated with. So you need to know what is the blood supply of the heart. And then we need to compare about the different leads which represent or are associated with the different surfaces of the heart. So let's have a close look at it. If this is your ascending aorta, it will divide, or it will give off two branches from its proximal part. So this would be your right coronary artery, this would be your left coronary artery. The left coronary artery in fact will divide into the left circumflex artery and the left anterior descending artery. The right coronary artery will be single and solitary and will curve around the lateral surface of the heart and go to the posterior aspect of the heart, where it will merge and form an anastomosis with the left circumflex artery and the left circumflex coronary artery, and it will also give off a branch known as the posterior interventricular artery, which is going to form an anastomosis with the left anterior descending artery as it curves around the apex of the heart and goes on the posterior surface of the heart. So things become very simple. It is just an anastomosis between the left coronary artery and the right coronary artery. The left one dividing into the left anterior descending artery and the left circumflex artery, both of which move over to the posterior surface of the heart respectively in the directions I am showing. This one around the lateral border, left circumflex artery, and this one winds around the apex of the heart from below and goes on the posterior surface, the left anterior descending artery. The right coronary artery winds around the auricles and goes to the posterior surface of the heart, where it anastomoses with the left circumflex coronary artery, and the right coronary artery, before it forms an anastomosis, gives off a posterior interventricular branch which supplies the posterior surface of the heart, and this in turn comes and anastomoses with the left anterior descending artery on the posterior surface of the heart. That's easy. And you would also know that yes, we have a septal branch arising from the left anterior descending artery. After knowing all this, so if I could just make it a bit clear for you, this is the left main coronary artery, this is the right main coronary artery, this is the left circumflex artery, this is the left anterior descending artery, this is the right coronary artery going further behind, this is the left circumflex artery going further behind, this is the posterior interventricular branch of the right coronary artery, and this is the septal branch. The different leads that we studied about look at some specific regions of the heart. Somebody looks at the anterior surface, somebody looks at the lateral surface, somebody looks at the posterior surface, right? So we need to have an idea about which leads look at which surface of the heart. So primarily, if we want to divide, right, if we want to divide, we could actually divide this entire concept which I am trying to explain to you into some subparts. Good. So just have a look. If we were to say that this is the name of the artery, this is the surface of the heart it preliminarily supplies, and these will be the leads where we would get the changes if those particular branches of the arteries are affected and blocked. Then the picture would come out to be something like this. If we have the left main coronary artery being affected, the surface of the heart which is being supplied is the anterior, which includes the anterior proper and the septal, as well as the lateral surface of the heart. If we have the left anterior descending artery which is being blocked, it is mainly the anterior surface of the heart, which again could be further subdivided into the septal branch and the LAD proper, right? So LAD proper. The septal branch would lead to an infarct of the septa, and the LAD proper infarct would lead to the affection of the anterior wall proper, right? The left circumflex artery would supply the lateral wall of the heart. The right coronary artery would be supplying the inferior wall of the heart, and the posterior interventricular artery or branch of the right coronary artery would mainly be supplying the posterior wall of the heart, right? Good. Now just to think that the inferior wall and the posterior wall, both of them would have contributions to the right ventricle, and we would be naming a special lead which specifically looks at pathologies of the right ventricle, but we'll come to that later. Let's first split this up. We've spoken about the left anterior descending artery. That itself will continue as LAD proper and it will give off a septal branch, right? So if the septal branch gets affected, the leads that would be showing the ST elevation or the corresponding changes associated with ischemia would be lead V1 and V2 of the chest. Yes, you might be asking me what would be the augmented leads affected, what would be the bipolar limb leads affected. Of course, they are lead 1 and lead AVL, which will be affected. Even if I don't say this, you must be knowing it. But if we are talking about the precordial chest leads, that yes, it's V1 and V2 which are affected. For the anterior wall proper being affected, it's lead V3 and V4. So for the anterior wall as a whole to be affected, we can say that V1 to V4 are affected. Are you getting the point? If the septal branch has a block, has a thrombus, ST elevation occurs in lead V1 and V2. If the LAD proper has a block distal to the point where it has given off the septal branch, it's lead V3 and V4 which show you the changes. If the LAD is blocked at a point above the septal branch, proximal to the point where it gives off the septal branch, then all the four are affected, V1 to V4, right? If the lateral wall is affected due to a thrombus in the LCX, left circumflex, is V5 and V6. All of them along with lead 1 and AVL, of course, that will be there. Needless to say. They are always affected. Good, but what after that? If you have a massive anterior wall MI, that means the left coronary artery, the main trunk of it is blocked, then you would have the findings from V1 to V6, because it would be an addition of the anterior wall infarct and the lateral wall infarct. So it would be an anterior lateral wall infarct along with lead 1 and lead AVL. If the right coronary artery is blocked, the inferior wall is affected. And if the inferior wall is affected, what you would see is we would get those changes, ST elevation, a tall tented T wave, whatever it is, I mean a hyperacute T wave, whatever it is, you would get the changes on lead 2, 3 and AVF. 2, 3 and AVF. And you would also read about this particular lead V4R, which looks specifically at the right ventricle of the heart. So if you have a right ventricular infarct, you might be interested to do a special lead placement V4R somewhere diametrically opposite to the V4. That means you have the left fifth intercostal space, a lead being placed at the left midclavicular line named as V4, and you would have in the right fifth intercostal space a lead being placed in the right midclavicular line, which would be known as V4R, and that would look directly into the right ventricle, right? And if you're talking about the posterior wall, posterior interventricular artery, then what would we see? That is where you would see the changes in the posteriorly placed leads, that is V7, V8 and V9. You would get ST elevation, and you would see a concurrent ST depression in the leads which are placed absolutely opposite to that, that is V1 to V4, especially V1 to V3, but sometimes V1 to V4. So V7, V8, V9 are on the back, and diametrically opposite to them you have V1, V2, V3 and sometimes V4. So that is where you would get an ST depression. So if you have a block in the posterior interventricular artery, then you would have ST elevation at the posterior placed leads V7, V8, V9 and a concomitant ST depression in the anteriorly placed leads, that is V1, V2, V3, V4, right? So now if we come to solve the question, to make your work a bit more easier for you, I'll just give you a complete lookout as to what I have been explaining till now. You see, the left anterior descending artery, if you have a block over here, this is what I'm marking this 2, I'm marking this as 2. You see, left anterior descending block, the entire anterior wall of the heart is afflicted, V1 to V4 leads 1 and AVL. If the block is proximal to the place where it gives off the septal branch, suppose just the septal branch is affected, then it is 2A, see, 2A septal branch, V1, V2, 1 AVL. Suppose just the LAD proper distal to where the septal branch has been given off, that is affected, you would have 2B, it would be V3, V4, 1 and AVL, right? Good. Suppose you have a block where there is the left circumflex coronary artery here, this is your number 3. So left circumflex coronary artery would have affliction of V5, V6, 1 and AVL, and suppose the mother artery of all of them, the left coronary artery proper, has a block marked as number 1. You have anterior plus lateral wall infarcts. So you would see the changes on V1 to V6, 1 in AVL. Suppose you have the block of the right coronary artery proper, the entire inferior wall of the heart suffers. I mark it as 4, leads 2, 3 and AVF, leads 2, 3 and AVF, right? And specifically for the right ventricle, V4R. V4R is not something we place as usual, but if we think it's an inferior wall infarct where we might have the right ventricular affliction, we might just place it to get the ST elevation and be very sure that yes, my right ventricle is suffering from ischemia or infarction, as the case may be. And for PIVA, posterior interventricular artery, that is a branch of the right coronary artery, you would have the posteriorly placed leads V7, V8, V9 showing ST elevation and concomitant ST depression on the anterior placed leads V1 to V4. So PIVA, if it is blocked, this is 5. Okay. So I think that gives you a clear enough picture of what I have tried to depict. 1, left main coronary artery, 1 AVL, V1 to V6, 2 left anterior descending artery, before it resolves the septal branch, V1 to V4, 1 AVL, 2A septal branch, 1 AVL, V1, V2, 2B left anterior descending artery, after it is given off the septal branch, that would mean V3, V4, 1 AVL, 3 left circumflex coronary artery, that would mean V5, V6, 1 AVL, just the lateral surface, 4 right coronary artery proper inferior wall, so leads 2, 3 AVF. If the right ventricle is affected, then V4R, and posterior interventricular branch of the right coronary artery posteriorly placed, so that's marked as number 5, leads V7, V8, V9 ST elevation, concomitant ST depression on the anteriorly placed leads V1 to V4. So your answer over here is, I hope everybody can say with confidence right now, the given leads, posteriorly placed leads, are useful in determining infarcts associated with posterior interventricular artery. Right main coronary artery is a very lucrative answer, but if you have a specific option being given as posterior interventricular artery, then you will mark that, because that is a specific branch of the right coronary artery which gets affected in posterior wall pathologies, and left circumflex coronary artery gives off to the lateral wall of the heart, so that is not associated with these leads. So that makes it very clear. So your answer is answer B, posterior interventricular artery. The next question you can see over here is very easy. I've shown you an ECG defect, and you have to comment on where is the pathology. So if you can see, what is the first thing which comes to your mind? You're just looking at this ECG strip, right? The first thing which should come to your mind, which is coming to my mind at least, is something's wrong here. Yes, you can see a sort of a small wave, possibly a P wave, but you don't see a Qrs complex, you don't see a T wave following that. So possibly it is suggesting a dropped beat. And the question reads, the given ECG depicts a defect in the SA node, AV node, bundle of his Purkinje fibers. See, when we first start studying bradyarrhythmias, the first thing we start studying about is heart blocks. And you know that only particular types of heart blocks are associated with dropped beats. But before I start hammering the nail on this topic, what I would like to bring to your notice is about a PR interval. You know that from the beginning of a P wave to the beginning of the Qrs complex, this interval that we have is a PR interval. And I hope most of you are aware as to what is the normal PR interval. So, normal PR interval, each small square in the x-axis is 40 milliseconds. I hope you know that. The ECG paper is 25 millimeters per second, and so 1 by 25.04 seconds, right? 0.04 seconds is 40 milliseconds. So normal PR interval is 3 to 5 small squares, 3 to 5 small squares, and if you multiply it by 40 milliseconds, it comes out to be 120 to 200 milliseconds. Now, when we talk about heart blocks, we are basically referring to the fact that this PR interval is getting prolonged. Now, how it is getting prolonged is dependent on the particular type of block we are talking about. So, just let's draw a simple diagram of the heart and then we'll go into the elaborate detailing of the pathology. So, if you have the SA node over here and you have the AV node over here, and you're connecting it with the bundles of Bachmann, Winky and Thorel. Okay, it's not a BMW, it's a BWT. Okay, and I'm dropping a bundle from here again. This is the bundle of his. Perhaps for your convenience, I should be drawing it something like this, bundle of his. Right, this is the AV node. And you know that the bundle itself continues as the right bundle and it gives off a branch to the left as a left bundle, and from there you have Purkinje fibers. So these are Purkinje fibers. Okay, good. The same diagram I am going to repeat it 3 more times so as to give you an idea about first degree heart block, second degree heart block Mobius type 1, second degree heart block Mobius type 2, and third degree heart block. Right, I think this should make it convenient for you. So, yes, I think we can discuss about the different types of heart block now. Where lies the problem? There lies the problem. If you don't know where lies the problem, there lies the problem. You might be wondering what I'm talking about. Where lies the problem? It must be somewhere in the conducting pathway. Yes, it is somewhere in the conducting pathway. If it's in the SA node, we would not be calling that heart block. We would be calling that sick sinus syndrome. If it's in the AV node, we will be calling it something else. If it is in the bundles connecting the SA node to the AV node, we'll be calling it something else. If it is in the bundle of His, we'll be calling it something else. So where is the pathology? Suppose a person has rheumatic fever and has developments of Aschoff nodules, and they get deposited on these bundles of Bachmann, Winky and Thorel. Right, these bundles. As a result of which, the impulse which originates from the SA node takes some time to come over to the AV node, and that prolongs the PR interval, because you know that the PR interval basically signifies the AV nodal delay. It is due to this AV nodal delay that the AV node cannot conduct more than 220 impulses from the atria to the ventricles per minute. Otherwise, if it were faster than that, the ventricles might fail due to oxygen dearth and decrease in diastolic time, during which the heart replenishes itself with coronary blood supply. I hope you are aware of that. So, if you have deposition of Aschoff nodules or iron granules in hemochromatosis, whatever the case may be, then you will find that there is slowness of conduction of impulses from the SA node to the AV node. And this block in these connecting fibers of Bachmann, Winky and Thorel connecting bundles gives rise to what you know as first degree heart block. So, in one word, if I were to tell you where is the pathology, it is supranodal. Supranodal. And in very short, if I were to tell you what would you find on the ECG, you would find an increased PR interval. Increased, what do I mean by increased? It is more than 200 milliseconds or 5 small squares, right? But it is more or less constant. It does not vary. And there is no skipped beat. There is no skipped beat. That means every P is followed by a QRS complex. Skip beat would mean that the P wave will not be followed by a QRS complex and a T wave. But in case it is followed, it is not a skip beat. That is all about your first degree heart block. What about your second degree heart block? So both these are second degree heart blocks. But both of them are completely different. This one is Mobius type 1, Mobius type 1. This one is Mobius type 2, Mobius type 2. Right. In the Mobius type 1 of second degree heart block, which is also known as the Winky-Back phenomenon, Winky-Back phenomenon, what actually happens is you have a malfunction of the AV node, but it is not completely stopped functioning. That means it conducts some impulses, it does not conduct some other impulses. Which impulse it will conduct, which it will not, you never really know. You can say as if it, in a propagating way or in a contiguous way, it is offering more and more resistance to each subsequent impulse that is trying to be propagated via it from the atria to the ventricles. That means you can say that somebody is closing a door and you are trying to make as many people pass through it as possible. In the first second, 5 people pass. In the second second, 4 people pass. In the third second, 5 people pass. In the 3 people pass. In the fourth second, 2 people pass. In the fifth second, only 1 person passes. In the sixth second, the door is completely closed and somebody is not able to pass. Rather, nobody is able to pass. Are you getting the point? I've just used a small example to make you understand how there is a decremental propagation of impulses from the SA node to the bundle of hairs via the AV node in Mobius type 1 grade 2 heart block. That means you will have progressive prolonging of the PR interval. That is very important. You will have progressive prolonging of the PR interval. It goes on increasing, it goes on increasing, and then suddenly there is one beat where the atria contracts because the SA node fires, but that does not reach the ventricles, so there is no QRS complex, so you have a skipped beat. And then again the PR interval comes back to normal and again it keeps on increasing. So just imagine this scenario very carefully. The door is being closed. First attempt, 5 people pass. The next time, the next second, 4 people pass because the aperture is becoming smaller. The next attempt, that means the next second, 3 people pass. The next second, 2 people pass. The next second, 1 person passes. The next second, nobody is able to pass and you have a drop beat. And again the person opens the door wide open. 5 people can pass. Again the next second, 4 people, 3 people, 2 people. What do I mean? The lesser the number of people that are being able to pass through the door, the longer is the PR interval. I hope you are understanding the point, because if it is a narrow aperture, people will take more time to just slip through that narrow aperture. So the PR interval is getting increased. You will have a progressive prolongation of the PR interval followed by a dropped beat where the P will not be followed by QRS. Again PR comes back to normal and again progressively increases. Again there's a drop beat and so on, it continues. That is Mobius type 1. And it is, as I already told you, it is an intranodal pathology. Intranodal pathology. Okay. But if you talk about Mobius type 2 heart block, second grade heart block, here the pathology does not lie in the AV node. Here the pathology lies in the bundle. What does that mean? That means even though the impulses are being conducted from the SA node to the AV node, whether they would be conducted via the bundles into the ventricles depends on the mood of the bundle itself. There is a rule that every second or every third second the door would remain closed. What does that mean? That means, or rather should I put it this way, every second or third second they open the door. The first second people go they see the door is not open, so no QRS complex. Second they go, door is not open, so no QRS complex. The third second they open the door and the people are able to pass through, so you have a QRS complex. The analogy which I am trying to draw over here is, whenever people are being able to pass through the door, you are having a ventricular depolarization, you are having a QRS complex. Whenever the people are not being able to pass through the door, an impulse is being fired from the SA node, but it is not being able to excite the ventricles, so there is no QRS complex, and we are coming in with the concept of a drop beat. So, in the case of second degree heart blocks, Mobius type 2, what you would have is a P wave, then maybe a P followed by QRS, or one P wave, one QRS. So you would have the pattern of a 2:1 or a 3:1 block. So over here you would see that the PR interval will not vary. The PR interval will not vary at all. It will depend on whether you have a drop beat after two waves. I mean, you have one QRS complex after two drop beats, or one QRS complex after three drop beats. That would determine this ratio of 2:1 or 3:1. What does this 2:1 or 3:1 mean? Every two atrial firings, the third one you have a ventricular let off bypass, that is 2:1 heart block. So it would be something like this: a P, and then a QRST, a P, and then a QRST. This would be a 2:1 block. If it were a P, QRST, a P, QRST, this would be a 3:1 block. I hope you're getting the difference. So over here you basically have skipped beats followed by QRS complexes, normal beats, and then again you have skipped beats. So, if you would just look into one skipped beat, suppose this one, and if I draw the ECG for this as well to make your concept easier, P, QRS, T, then P, QRS, T, then just a P, then again P, QRS, T. I just kept it down to 2 to not make it complicated, but the point over here which I am trying to make, if you just look at this skipped beat over here and you look at this skipped beat, it's easier to understand over here. If I calculate the PR interval of the wave in front of it or preceding this skipped beat and the PR interval of the wave succeeding this skipped beat, I would see it is almost equal. But if I look at the PR interval of the wave preceding the Mobius type 1 heart block, Venky back phenomenon, and the PR interval of the wave succeeding it, definitely the one preceding it is greater than the one succeeding it. So that would be a shorthand way of how I could differentiate a Mobius type 1 heart block, where the preceding beat to the skip beat, the preceding normal beat to a skip beat would have a greater PR interval than the succeeding normal beat following the skip beat in comparison to the Mobius type 2 heart block, where you would just have a fixed ratio of the skip beats and the normal beats, 2:1, 3:1, whatever it may happen. And if you consider a particular skip beat, the preceding one and the succeeding one, the normal beats, would have an equal PR interval. Just get the concept clear in your heads again. Since we have a progressive increase of the PR interval followed by a skip beat, then normal PR interval, and again progressive increase of the PR interval, again a skip beat, this type of pattern in Mobius type 1 grade 2 heart block. So in that case, if you measure the PR interval of the normal wave preceding the skip beat and PR interval of a normal wave succeeding the skip beat, the preceding PR interval would be greater than the succeeding PR interval. They would be unequal. But if you are to compare the PR interval of a normal wave preceding and a normal wave succeeding the skip beat in a 2:1 or a 3:1 block, in a case of Mobius type 2 heart block, you would see that the PR interval is going to remain same. It's just that in a particular fixed ratio, you are having the skip beats and the normal beats interspersed along each other. 2:1 would mean every 2 skip beats you have a normal beat, 3:1 every 3 skip beats you have a normal beat. That is the basic rationale of it all. And if you just realize it is due to a block in the bundle of His which is not conducting the impulse down to the ventricles, so it is an infranodal pathology. It is an infranodal pathology. And of course, you have our very own third degree heart block. It is due to a complete non-function of the AV node. The AV node stops functioning altogether. None of the waves which originate, none of the impulses which originate in the SA node are supplied across the AV node into the ventricles, as a result of which what happens? Very easy, there is atrioventricular dissociation. Atrioventricular dissociation, that means the atria and ventricles start beating at their own rhythms. The atria firing at the SA nodal frequency of around 100 per minute, whereas the ventricles beating at the frequency generated intrinsically by the bundle of His at around 15 to 40 beats per minute. So it is one of the cases where you see an atrioventricular dissociation, the atria and the ventricle firing at their own merry rates without any coordination with each other. In such a case, what could happen is the person could suddenly develop Stokes-Adams syndrome, because due to this incoordinated contraction between the atria and the ventricles, the cardiac output drops drastically and the perfusion to the cerebral blood vessels also drops, as a result of which, due to cerebral anoxia, the person feels dizzy and just falls down. So this is Stokes-Adams syndrome. And you might need a biventricular pacemaker, cardiac resynchronization therapy in order to stabilize this patient again, and it is a very life-threatening event as well. Another place where you would see an AV dissociation is the ventricular tachycardia. There an injury focus inside the ventricles lets off injury currents which makes the ventricles beat at higher rates, say 240, 250 beats per minute, whereas the atria is only being able to fire at 100 beats per minute. So there also there is a disparity between the atrial and ventricular contractions which could be life-threatening, especially if it progresses to a ventricular fibrillation. So these were some of the concepts, and so you can know this is an intranodal pathology. And in this case we have two different atria and ventricular rates which you can, I guess, already understand. You have a P wave over here, you have a QRS interval over here, then maybe a T over here, then a P, and then another QRS over here, and then a T, right? So you'd see that the RR interval and the PP interval are not equal, and this PP interval 1500 by that number of small squares or 300 by number of large squares will give you the atrial rate, and this RR interval will give you the ventricular rate, right? So coming to the crux of the question, the given ECG depicts a defect in the, so first you have to diagnose and then decide where the defect lies. See, already we talked about this dot beat over here. So measure the PR interval preceding it from here to here, say 2 large squares, and measure the PR interval succeeding it, say from here to here. So it's around 3 to 5 small squares, that means 1 large square. This is 5 small squares, this is 10 small squares. So you can understand the preceding beat, PR interval preceding more than PR interval succeeding. So I already taught you the shorthand formula. It is a, yes, Mobius type 1, Mobius type 1, grade 2 heart block, grade 2 or second degree, that's the way you call it, second degree heart block, right? You can just check it. You see the PR interval it's something like this. It keeps on increasing, it increases further, then you have this drought beat, and then again it's back to normal, and again it's increasing. So yes, you can corroborate the pathology as well. It's just like the pattern I told you. The PR interval increases, and then you have a drop beat, and again it increases. If it would have been a Mobius type 2, what you would have particularly seen is that the PR interval would not have increased like that. What rather you would have seen is interspersed in between some drop beats, you would have a fixed ratio of the drop beats to a normal Qrs complex or a normal wave. So that is completely different. You can't confuse it. Definitely it's not a first degree heart block. The PR interval would have been constant. It's not over here, it's progressively increasing. And a third degree heart block would have AV dissociation. We see that the PP and the RR intervals are equal over here. You see from this P to this P, it is almost 4 large squares, maybe 4 large squares and 2 small squares. And between this R and this R, again you would see that it's almost the same. So it's not a third degree heart block, of course. So now that we have decided that it is Mobius type 1 of second degree heart block, Venky back phenomenon, I told you where the pathology lies. So just a quick revision of where the pathologies lie. If it is a 6 sinus syndrome, the pathology lies in the SA node. If it is a first degree heart block, the pathology lies in the bundles of Bachmann, Winky back and Thorel. That means between the SA and AV nodes. Right. If you have a second degree heart block, Mobius type 1, then the pathology lies in the AV node. If you have a second degree heart block, Mobius type 2, the pathology lies in the bundle of His. And if you have a third degree heart block, complete dissociation, then it lies in the AV node. Just that the difference between second degree Mobius 1 and third degree heart block is that over here it is a partial stoppage of activity of the AV node, and over here is a complete cessation of activity of the AV node. So since we have Mobius type 1 second degree heart block, it is an intranodal pathology. So the correct answer over here would be AV node. Definitely not SA node. It's not 6 sinus syndrome. Purkinje fibers being affected don't cause any major disorder. Bundle of His would have caused Mobius type 2 heart block, but over there you would have seen that the PR interval preceding it and the PR interval succeeding it would have been equal. It is unequal in this case, the preceding one being greater than the succeeding one. So it is a Winky back phenomenon, second degree heart block, Mobius type 1. So it is not an infranodal pathology like Mobius type 2, but Mobius type 1 is an intranodal pathology. So AV node is affected. There you go. So now let's have a look at this question. I think the question, if you already read it, you might be thinking, what is such a weird question all about? See, the concept is not weird at all, just that you need to apply it. We've shown you an ECG and then we've told you that all of the following conditions in this ECG could be possible except. So yes, we have not given you any specific diagnosis maybe, but we have given you a subtle clue. If you look at the options which have been given, left ventricular hypertrophy, anterolateral wall myocardial infarction, right ventricular hypertrophy and left bundle branch block. So if you remember a bit of your physiology, or what I am talking about right now is basically something known as axis calculation. It is a very neglected part of our ECG analysis, I understand that. Now with the advent of modern machines, we get machinery values, so we don't even bother calculating it manually. But sometimes if you are in PHCs or where you don't have ECG machines which give you printed out axis values, it might just be good to know shorthand ways to calculate it, you know that. And after we calculate axis from the ECG strip which is being shown over here, then it would be quite easy to rule out which one would not fit into the scheme of things we are going to discuss about. So if we are talking about axis, I hope most of you are familiar with this diagram which I am going to draw over here. If this is the heart most of you would be familiar with this sort of a diagram, that the direction of lead 1 is something like this. Okay, always remember it's negative to positive, right? I'm not drawing it for every one of them. The direction of lead 2 is downwards and to the left, something like this. Direction of lead 3 is exactly on the opposite side like lead 2, right? Then you have the AVR lead, which is exactly in parallel and opposite to lead 2. Parallel and opposite to lead 3, you have the AVL lead, and vertically downwards you have the AVF lead, right? And of course you have the chest leads in front over here, as you can make out V1, V2, V3, V4, V5 and V6. If we are to calculate the axis, it is simple coordinate geometry. In coordinate geometry, we had an x-axis, we had a y-axis. So just looking at this diagram, can you understand which is the x-axis and which is the y-axis? Yes, it's pretty evident in front of you. This lead 1 looks pretty much like an x-axis, and this lead AVF looks pretty much like a y-axis. The next question you might just be coming up with asking me, sir, in coordinate geometry we have a negative quadrant and a positive quadrant, but over here you have not shown any signs. So how do we transpose or interpose this lead 1 and AVF into the x-axis and y-axis we are used to on a graph paper? So I'll just tell you that the direction of the lead which we show conventionally is always from the negative direction of the electrode to the positive direction of the electrode. So now I think it becomes pretty easy for you to understand. The arrow faces towards the positive electrode. So if you just cut out what we've tried to show over here, you could use this line, horizontal line, as your lead 1, right? And say that this is your positive end and this is your negative end of the thing, because we've just followed the dictum I've showed to you over here, negative, positive. So similarly, negative, positive, right? And if we draw the vertical line over here as a y-axis representing lead AVF, again below it will be positive, above it will be negative. And now we need to do a simple thing. We need to plot some points, but how will we plot the points? So I'll just take you back to this ECG strip. We need to do a very simple thing. We need to take the absolute difference in small squares or millivolt. You know that on the y-axis 1 small square is equals to 0.1 millivolt, right? You know that. So basically you're going to take the difference between the amplitude of the largest positive reflection and the amplitude of the largest negative reflection. In simple words, the amplitude of the R wave, largest positive reflection, minus the amplitude of the largest negative wave, which usually is the S wave, right? So if you look at lead 1, which we've taken as the x-axis, you see that if we count the number of small squares this tall R wave has, it's around 3 large squares and 3 small squares, so that comes around 18 small squares. 18 small squares. And definitely, if you're taking the negative S wave, it's hardly around 1 small square over here. So if this is your R wave and this is your S wave, then for lead 1, R minus S comes out to be 18 minus 1, that is 17 small squares. So overall you can say it is a positive value. It is a positive value. And if you look at lead AVF over here, if you calculate the height of the R wave, you will see that it is around 4 small squares at maximum, maybe even 3. And if you look at the deep wave which we are seeing over here, it's around 5 to 6, maybe 6 small squares. So R is 4 small squares, S is 6 small squares, so R minus S for lead AVF is minus 2 small squares. So basically it is a negative value. So you just saw how we had a positive value of R minus S in lead 1 and how we had a negative value of R minus S in lead AVF. Now what do we interpret from it? Let's come back to this diagram which we had drawn over here. If this is our coordinate geometry axis, I give you a random fact right now and you need to remember it throughout the continuance period of whatever you're studying ECG for, that the normal axis of the heart is between minus 30 to plus 110, and I am quoting standard textbooks on ECG, including your 20th edition Harrison. It says that yes, it is minus 30 to plus 110. So note that value. Minus 30, so if this is minus 90, minus 30 would be somewhere here. Minus 30 to plus 110. If this is plus 90, then this is plus 110. So anything which comes in between this is normal axis. Right. Just here shade it. This is the normal axis. This is your normal axis. If I were to make a table of R minus S in lead 1, R minus S in lead AVF, right, the axis and examples of such axis deviation, it would be much easier for us to understand. Suppose we had R greater than S, so R minus S positive in lead 1, and R greater than S, that means R minus S positive in lead AVF, then just plot it. Hypothetically, let's plot it. Lead 1, we have a positive value. Lead AVF, we also have a positive value. See, I am giving the points, I am marking the points in the positive quadrants. It's simple coordinate geometry. Then we draw perpendiculars from here. We drop a perpendicular from here, and we try to make a line pass through the center of the intersection with the center origin over here, and you see it will lie in the normal axis. So the axis is normal, and you would have a normal heart functioning. Or some other scenarios where you will not have a massive demand or demand supply imbalance, which would fall under the normal axis category. But if you have a heart which has a right ventricular hypertrophy, a left ventricular hypertrophy, a left bundle branch block, a left anterior hemiblock, a left posterior hemiblock, a right bundle branch block, anterolateral wall MI, an inferior wall MI, a ventricular tachycardia, they would not be falling under the normal axis category. In such a case, let's say suppose what we just showed you in the ECG over here, right? R minus S in lead 1 is positive and R minus S in lead AVF is negative. If we just take that very example, R minus S is positive in lead 1, R greater than S, but R less than S in lead AVF, so we have negative over here. What that would mean is it is a left axis deviation. But how do we know that? Just because I say it doesn't happen. What you see is what you know, so you need to know what we are speaking about. So I said on lead 1 you would have a positive point, you already have a positive point. And on lead AVF you have a negative point. So again, following the same logic, coordinate geometry, draw perpendiculars, and then make a line pass through the origin through this point, right? And you would see it is coming to the left of the normal axis. So this is left axis deviation. Left axis deviation. And where would we find this left axis deviation? Left ventricular hypertrophy, left bundle branch block, left anterior hemiblock, anterolateral wall MI. Just imagine if we were to revert things and say that R minus S is negative on lead 1 and R minus S is positive on lead AVF. That means R is more than S on lead AVF and R is less than S on lead 1. Then let's plot the thing. On lead 1 it is negative, so let's plot a negative point on lead 1, and we can plot a positive point on lead AVF over here. Again, join them, draw perpendiculars. Okay. Let's do this. Drop a perpendicular from here, right? Alright, and then you see that this is coming on the opposite direction, that is to the right of the normal axis, so we would call it a right axis deviation. A right axis deviation. Where would we find this? A right ventricular hypertrophy, left posterior hemiblock, sometimes even in your right bundle branch blocks, and in an inferior wall MI, right? And if we would have both negative, what would you do in such a case? Suppose we use this color. If you need to plot one negative point here and one negative point here, join them up, and pass a line through the origin and the point of intersection of these two, this would be your indeterminate axis. This I have already stated as right axis deviation. So in case you have R minus S negative on both lead 1 and lead AVF, that means R is less than S on both lead 1 and lead AVF, you have indeterminate axis. And this indeterminate axis usually associated with ventricular tachycardia. Now let's come to solve our question, that you know this already. Since we've discussed this, you've seen R minus S is positive in lead 1, R minus S is negative in lead AVF, so it's a left axis deviation. And so our question, ECG could indicate all of the following except, so which of the following are examples of left axis deviation? Left ventricular hypertrophy, yes, left axis deviation is there. Anterolateral wall MI, yes, left axis deviation is there. Right ventricular hypertrophy, no, right axis deviation is there. Left bundle branch block, yes, left axis deviation is there. So the odd one out, and the answer to your question is right ventricular hypertrophy. I hope the concept is cleared. So friends, let's come to this strip which we have in front of us. What is it? The given ECG is commonly associated with, can you find something abnormal on this ECG strip? Tell me first. Yes, the P wave is not normal, but what is so abnormal about the P wave? We need to know that, right? Do you know what is a normal P wave? That is the first thing I need to know, otherwise this entire discussion becomes pretty irrelevant. So a P wave has a particular width and a P wave has a normal height. So any of the scenarios, if the P wave becomes taller than what it should be, or it becomes wider than what it should be, then it is an abnormal P wave. So yes, let's just see your knowledge on the P wave, how good or not so good it is. So the P wave, the normal P wave, what is its width? What is its height? Yes, anyone? What is its width? What is the normal width of the P wave? Yes, 3 small squares or 120 milliseconds. Less than that. Right? So let's just make it a bit tidy. Less than 120 milliseconds. Remember that, that should serve your purpose. Less than 120 milliseconds is the normal width of the P wave. What is its height? Important point. The height would depend on whether you're taking the reading in a chest lead or a limb lead. I told you as a rule, usually the cutoffs for waves are higher in the chest leads, because we are taking an ECG, the heart is closer to the precordium than the limbs, so the cutoffs would be greater in the chest leads, because the amplitudes of the electrical activity of the heart, which is being recorded by the electrodes placed on the precordium or the chest wall, is going to be of a greater magnitude compared to that perceived by the limb electrodes placed on the limbs. Furthermore, we are taking potential differences over there, but we are taking absolute potentials over here. So the cutoffs would be greater in the chest leads than the limb leads, with the exception of the P wave, because the P wave depicts atrial depolarization, and as you know, the atria are more inclined posteriorly, closer to the limbs, so the magnitude of the atrial activity would be better depicted by the limb electrodes. So we would have a higher cutoff for the P wave in the limb electrodes than the chest electrodes, right? So what is this cutoff? That is a very important point. So for the chest leads, a P wave having amplitude less than 1.5 millimeter is normal, and for the limb leads, P wave with a height of less than 2.5 millimeter is normal, right? So again I told you that the chest leads cutoff is usually higher for all of them, but for the P wave the chest leads cutoff is lower. And how low is it? Less than 1.5 millimeter. And the limb lead cutoff is usually lower, but for the P wave it is higher. How much? It is more than is less than 2.5 millimeters for the limb leads, right? But now we'll come to the abnormalities of the P wave. To make it very easy for you, the P wave can be taller than normal, it can be wider than normal. But before discussing that, let's just divide the P wave. You see, a normal P wave is like this, somewhat like this. So I told you this width should be less than 120 milliseconds, and this height should be less than 1.5 millimeter in the chest leads and less than 2.5 millimeter in the limb leads. Furthermore, one thing which I will need to add on, one thing which I will really need to add on over here is that you can further subdivide this P wave. The initial part of it represents the right atrial depolarization, and the later part of it represents the left atrial depolarization. So if any of these events, the right atrial depolarization or the left atrial depolarization, will take more time, that could reflect as a change in the shape of the P wave. It would become wider. And if the right atria is having to contract with more force and it is depolarizing with a greater amplitude, that would actually, not only the right atrium, both the atria, that would make the P wave taller than normal. So these are the two changes we'll talk about. So it's P pulmonale and P mitral, P pulmonale and P mitral. Right. So what is P pulmonale and what is P mitral? That is important. Okay, let's come to it. P pulmonale is a tall P wave. Let's just call it a tall P wave, which has a height of more than 1.5 millimeters in the chest leads and a height of more than 2.5 millimeters in the limb leads. Right. So P pulmonale is usually, why is it called P pulmonale? Because it is seen in patients who have pulmonary arterial hypertension. In patients who have pulmonary arterial hypertension, the pressure is exerted back into the right ventricle and from the right ventricle into the right atria, leading to a right atrial hypertrophy or dilatation, as you can call it, right? So right atrial hypertrophy or dilatation. And it is this right atrial hypertrophy or dilatation that basically leads to your tall P wave, right? So let's just see how it would look. This is how it would look, where you would see that the P wave, the height would be more than 1.5 millimeters in the chest leads, and it would be more than 2.5 millimeters in the limb leads. Getting the point right now? Absolutely. So more than 2.5 millimeters in the limb leads and more than 1.5 millimeters in the chest leads. Good. This is P pulmonale, which occurs in pulmonary arterial hypertension due to right atrial hypertrophy and dilatation. But suppose we have a patient of mitral stenosis. In this patient of mitral stenosis, what will happen is the blood is not being able to go flow freely from the left atrium to the left ventricle, as a result of which there will be left atrial hypertrophy and dilatation. Left atrial hypertrophy and dilatation. Right. So since you would have a left atrial hypertrophy and dilatation, if you just look at the normal P wave, it is like this. You have the right atrial depolarization part and the left atrial depolarization part. You know that when the left atrium will start getting dilated, the muscle fibers will get damaged and they will be replaced by fibrosis, and also some of the junctional tissues, they will also be replaced by fibrosis. So there will be ineffective electrical conduction, as well as there would be ineffective contraction on part of the left atrium. As a result of which, what you will see, the left atrium will comparatively take a fraction of a second more than the normal time it takes to depolarize or contract in normal, as compared to what it would happen in a case of a mitral stenosis. So if I would say that you would have a normal smooth curve in a person having a normal right and left atrial depolarization, for this person, this curve would turn out to be something like, you're having the normal right atrial depolarization, but your left atrial depolarization is going to take some more time, so you are having a bifid or a notched P wave. Right. You're having a bifid or a notched P wave, and that is your characteristic of P mitrally, which is seen in mitral stenosis and which is characteristic of a left atrial hypertrophy. You see, you have a bifid or notched P wave, and of course, this is all these findings I am pertaining to is seen in lead 2. But in case of a left atrial hypertrophy, if you would just take some time to look at lead V1, you might also see that there could be a biphasic P wave, something like this, right? This would indicate the right atrial depolarization, this would indicate the left atrial depolarization, and that basically would be seen in lead V1, especially in case you have a left atrial hypertrophy in P mitrally associated with mitral stenosis. So this is what we've discussed. Now let's come to the question. The given ECG is commonly associated with, you can see it is lead 2, and in lead 2 you have a bifid or notched P wave with this width being more than 3 small squares, so more than 120 milliseconds, which it is normally, right? So what is it? What is the name of this condition? Yes, it is P mitrally. Told you, na? P pulmonally is tall P wave seen in pulmonary arterial hypertension associated with right atrial hypertrophy, and if you have a bifid or a notched P wave seen in mitral stenosis associated with left atrial hypertrophy, it is a P mitrally. So P mitrally is associated with mitral stenosis, and the answer is pretty clear. If you have a single best response to choose from here, mitral stenosis. Tetralogy of Fallot, no, it will lead to pulmonary arterial hypertension that could secondarily give rise to a tall P or P pulmonally. Aortic regurgitation per se will not give rise to P wave changes. Long-standing aortic regurgitation could lead to P mitrally due to a functional outflow tract obstruction from the left atrium to the left ventricle, and ventricular septal defect again shunts blood from the left to the right. It could give rise to a pulmonary arterial hypertension. Long term it could give rise to a P pulmonally as well, but in no way P mitrally. So P mitrally, the most suitable answer you get over here, and as you can see from the ECG, this is a P mitrally, a bifid or notched P wave would be mitral stenosis. Given before you is an ECG strip, and there are some very interesting options given alongside the ECG strip. The given ECG depicts a condition which is either commonly seen in smokers, or presents with a pulse apex deficit, or has ibutilide as a drug of choice for rate control, or requires a DC shock of 20 joules to be given for electrical cardioversion. Yes, as you've already understood, you have to choose the correct option out of them. And which one is the correct option after all? You need to know that. So, the thing is very simple and clear that you would need to know something about the etiology, the epidemiology, the pathophysiology, the treatment protocols, complications, and then we will be able to understand this entire topic and purview of this MCQ, what it deals about. Yes, so just to make your work easier, let's draw a box diagram of the heart. One good diagram is worth 1,000 boring words. I heard that when I was in first year medical school. So, as you can see, yes, there's a right atrium, there's a right ventricle, there's a left atrium, there's a left ventricle, and in this condition of atrial fibrillation, you have multiple foci of injury currents originating from the left atrium. And since the left side of the heart is the major brunt of electrical as well as vascular activity, so the changes which will occur on the left side of the heart, presumably over here in the left atrium, will be picked up by most of the leads, rather all the leads. Comparing it with another similar type of pathology, supraventricular tachycardia, atrial flutter, where there is one single focus of injury at the cavo-tricuspid isthmus situated in the right atrium, where only the right-sided leads are able to pick up the electrical activity. So that is something you need to be concerned about. That's why I just mentioned it. So you have, yes, multiple foci of injury currents coming in from here, firing at a very fast rate at around 300 to 600 beats per minute. So the atrial rate we are concerned about over here is 300 to 600 beats per minute, and they are coming to the AV node. As you can see, this is the AV node, and the SA node is firing at 100 beats per minute, and that too is coming to the AV node, and they are having a fight. And as you understand, survival of the fittest, this is not fit, this is just high frequencies, whatever it is, whoever delivers the goods faster gets the order. Similarly, whoever has a faster firing frequency is able to surpass the other and travel across the AV node. But the AV node, of course, does not allow 600 beats to be transmitted across it to the ventricles. It has a limit, and it has to limit the maximum number of transmitted impulses to 220. So it will exert a particular amount of atrioventricular block, something around 4:1 block. That means for every 4 people who come to it and say, sir, I have to go through this gate, it will just allow 1 person to go through. And so the ventricular rate, or the number of people sitting on the boat in the ventricle, becomes something around 600 by 4, which is 150 beats per minute. Right. So this is the atrial rate and this is the ventricular rate. One common thing you would realize that you know what is a holiday heart syndrome? Holiday heart syndrome. Holiday heart syndrome is where alcoholics usually booze and spend a day out enjoying their weekends, and then suddenly they catch their breath, hold their left side of the chest, fall down and die. What suddenly caused the death? It was definitely not, possibly not, an acute coronary syndrome. Yes, it was an acute attack of atrial fibrillation. So usually you see in alcoholics who suffer from a dilated cardiomyopathy, there may be sudden cardiac death due to atrial fibrillation. So this is one point about the epidemiology as well as the etiology you need to know. Pathophysiology we've already discussed. Then what lies next? The ECG findings and the treatment. ECG findings, I showed you the ECG strip. Look carefully, you have narrow complex QRS. So the normal QRS complex is 80 to 100 milliseconds, 2 to 2.5 small squares, and you can just realize this is much less than 2 small squares, this is much less than 2 small squares, so it is a narrow complex QRS. It is a narrow complex QRS. Yes, it is a narrow complex QRS, and since it is a narrow complex QRS, what you will also be observing is that the heart rate is higher. And I already told you during rate calculation that if the heart rate is higher than normal, the normal heart rate is 60 to 100 beats per minute. I already told you that the ventricular rate itself is around 150 beats per minute. So you will have closely spaced QRS complexes. You see, it's less than 3 large squares, less than 3 large squares. So you have closely spaced QRS or decreased RR interval, as you want to say. But these RR intervals are irregular RR interval spacing, irregular RR interval spacing. And if you realize there are no P waves, that means basically the wave of atrial depolarization is absent. Even if you do a JVP, the A wave of the JVP will be absent, right? And the S4, the fourth heart sound, will be absent, which is the atrial gallop. So these are the things which are absent in atrial fibrillation. In the ECG, as I already told you, yes, you will have a narrow complex QRS, you will have a decreased RR interval, which will be irregular, variable, and of course, you also realize that you have absence of P waves. That is pretty important. See, understand one thing. In any supraventricular tachycardia, you would have narrow QRS complexes. Of course, no problem with that. Now you have to see, and usually you will have tachycardia, so the RR intervals will also be reduced. But you need to see if these RR interval are regular or irregular. If they are regular, you would rather think of maybe an atrial flutter. But if they are irregular, you would think of atrial fibrillation or perhaps multifocal atrial tachycardia. Now you would have to look at the morphology after that. That means you have excluded atrial flutter because you would have normal flutter waves out there. But if you're seeing at absence of P waves or abnormal P waves, different morphologies of the P wave, you would be thinking absence of P waves, atrial fibrillation, and different morphology of the P waves, you would be thinking about multifocal atrial tachycardia. The message was very simple. How do you differentiate a supraventricular tachycardia from a ventricular tachycardia? Narrow QRS complex, supraventricular tachycardia. After that, and usually you would have a high heart rate, so you would have narrow RR intervals. Within those narrow RR intervals, you would see whether the RR intervals are regular or irregular. You just see over here, you have around 4 large squares in between 2 RR, and over here only 3 large squares. Again, only 2 large squares. Again, over here you would have something around 3 large squares. So it is varying. It's variable, right? So if it is variable, you would either think atrial fibrillation or multifocal atrial tachycardia. If it is not variable, if it is constant, you would think atrial flutter, and it would have flutter waves in between, usually on the right sided leads. If you did not find it was regular, you found it was irregular, it could either be atrial fibrillation, where you will have no P waves. There are no P waves over here. There's a T wave, there's a T wave, there's a T wave, but there's no P wave, there's no P wave, there's no P wave, right? So it would be an atrial fibrillation, and if you find different morphologies of the P wave and the PR interval, RR interval, everything varies, and you have different morphologies of the P wave, that would basically indicate that yes, you are dealing with a multifocal atrial tachycardia, apart from the axis deviation and other things which you would find in the lead V6, you might find a deep S wave, right? So all that is there, but we'll discuss that separately. Right now we are more concerned with atrial fibrillation, and apart from the fact that atrial fibrillation, you have these characteristic ECG findings, I would also be interested in discussing with you some of the clinical features of atrial fibrillation. It's basically, there's a bedside triad by which you can define it or diagnose it. You have irregularly irregular pulse. Usually the 3 differential diagnoses you asked in your bedside clinics about irregularly irregular pulse are atrial fibrillation, atrial flutter with varying degree of heart block, and multifocal atrial tachycardia, right? Then apart from that, you realize that since the atria are contracting like a bag of worms, every time it will contract, it will not be able to pump out sufficient amount of blood which will be able to produce a pulse with a volume subtle enough which we can feel. So even though if you might auscultate the heart over here, you would hear a sound of the heart beating, you might not get a pulse corresponding to it. These are known as pulse apex deficits. And if the pulse apex deficit is more than 10, pulse apex deficit is more than 10, along with the fact that you have muffled S1 and S2, then yes, you can say that clinically you have diagnosed a case of atrial fibrillation. I already told you the ECG findings, because ECG findings are what you usually get confused about. So I just dealt with that before. In case you're writing a clinical answer in your final prof, it would be better you write the clinical features first and then you write the ECG findings. What about the treatment? So the treatment is in accordance with the RACE protocol. I won't be going into the details of doses right now. You can watch the videos for that. But yes, the first thing, already I told you again, the heart is beating very fast and it is irregular. But the first thing you need to control is the rate of the heart. If the heart is beating too fast, it will exhaust itself, it will run out of its own blood supply and it will have an ischemic attack and the person might just collapse and die. So the first thing is not to get the heart back into rhythm, it is to control its rate. It's much like if you're in a good relation with your friend and you have a quarrel, the first thing you do is not get to the depth of the reason of the quarrel, who is at fault, but the first thing you end the quarrel and become friends with the friend again, otherwise you lose the friend. Similarly, if you don't address the issue of the rate over here, the heart will run out of its own blood supply, there will be a gross mismatch between the supply and demand, the heart will turn ischemic, it will necrose and the heart will stop beating, you will have a cardiac arrest. So the cardiac arrest mainly deals with electrical phenomena, and in case of vascular phenomena we call it acute coronary syndrome and infarction. So basically ultimately you are going to expire, you are going to lose the patient if his heart runs so fast. So the first thing you do is rate control. And which are the drugs you usually prefer for rate control? There was an era when we used to go for cardioselective calcium channel blockers, verapamil. You still use verapamil, no doubt. But since this is an event where you would require a sudden downgrading of the heart rate, so it's better we directly block the beta 1 receptors with a very short acting beta blocker known as esmolol. IV esmolol is nowadays the standard drug which we use, right, for the rate control part of it. Next, after that, our prime concern is to bring back the heart into normal rhythm. But realize one thing, I already told you in my discussions before, that if the heart, especially the left atrium, due to a case of say mitral stenosis or rheumatic heart disease, is damaged, both the fibers, the muscle fibers along with the junctional fibers, all of them are damaged. So the heart is neither able to conduct impulses properly, nor is it able to contract properly, so it keeps contracting like a bag of worms in an irregularly paced rhythm. That is the pathophysiology of your atrial fibrillation. That means ineffective contractions at an irregular rate. Ineffective contractions, since the muscle fibers are damaged and replaced by fibrous tissue which can neither distend nor contract properly, and at an irregular rate because the junctional fibers, the electrical fibers of the heart, also replaced by junctional tissue, so that there is improper conduction, sometimes intermyocyte conduction, so you don't get a proper electrical impulse. If in such a patient, suddenly without doing anything else, I give that person a DC shock to pace his heart back into normal rhythm, a complication which is going to arise is, you realize what is Virchow's triad. Things which promote thrombosis in our body. What are they? Endothelial injury, yes, there has been an injury over there. Stasis, the heart is not being able to pump blood properly, so blood is being stored over there, collected over there, blood is undergoing stasis, and you have hypercoagulability in such situations. So your Virchow's triad positive means you might be having blood clots formed and stored in your left atrial appendage, and the moment you give a DC shock to this patient, these emboli or these thrombi could embolize into your cerebral circulation and lead to an acute ischemic stroke. You wouldn't want that, of course. You would lose your patient if his vital centers are switched off. So in such a case, what do? Yes, you would first go in for anticoagulation. The anticoagulation which is usually preferred is with the help of the NOACs, you know, the novel oral anticoagulant agents, and generally we would go in for a dabigatran. That is one of the drugs we use nowadays, or a rivaroxaban, right? So you would go in for dabigatran or a rivaroxaban. Rivaroxaban has a X in it. X means factor 10, so it's a directly acting oral factor 10A inhibitor, and dabigatran is a directly acting oral thrombin inhibitor. So you could go in for them and anticoagulate the patient, right, before you go in for a cardioversion. Now this cardioversion, or reverting the heart back into normal rhythm, could either be in the form of chemical cardioversion, that means you give a drug to bring the heart back into normal rhythm, or electrical cardioversion, you give an electrical shock. What is the drug you use? Yes, IV butylide. Chemical cardioversion, the drug you use is IV butylide. Very good. And what do you do about the electrical cardioversion? What is the amplitude of the shock you use? It is a large amplitude shock you use, not the 20 or 25 one you use for the atrial flutter. It is a much larger one, 200. Yes, 200 joules biphasic DC shock has to be used. 200 joules biphasic DC shock. Now let's come to the MCQ and see what we were discussing about. The given ECG depicts a condition. It is atrial fibrillation. I've already told you. You can see the Qrs complexes which are very narrow. Apart from that, you know it is a supraventricular tachycardia. Then you can see that the RR intervals are narrowly spaced, so you have an increased heart rate, corroborative, good enough. Next thing, you were out to see whether they are irregular or regular. The RR intervals, they are irregular, as I've already shown you. So it is perhaps either MAT or atrial fibrillation, but you don't have a P wave, so it is atrial fibrillation, right? Atrial fibrillation commonly seen in smokers? No. Alcoholic, DCM, atrial fibrillation, holiday heart syndrome is not smokers. Smokers, usually it is atrial flutter, right? Presents with a pulse apex deficit? Yes. Has ibutylide as a drug of choice for rate control? No. Rate control, we used esmolol, I presume, and verapamil. Ibutylide was for rhythm control, chemical cardioversion, and requires a DC shock of 20 joules to be given. No, 20 joules is for atrial flutter, it's 200 joules for atrial fibrillation. So your correct answer, very evidently, is the patient presents with a pulse apex deficit of more than 10, which is the bedside clinical diagnostic criteria for patients of atrial fibrillation. So I presume you can see this tracing on the monitor. Look at this tracing carefully. All right. I hope you have been able to understand this tracing. So, dear friends, I think you've seen the video clip which we were just playing, and here's the still clip from there. So the question reads, which of the following is usually not included as a form of treatment in the conditions shown above? And we have the options as carotid sinus massage, a DC shock, IV adenosine, and IV epinephrine, right? So firstly, you'll need to know what the condition is and how do we treat it, and then choose the odd one out. To diagnose the condition, first let's come to one fact. Can you see that we have narrow Qrs complex? So we have a narrow Qrs complex, right? So you can understand it is a supraventricular tachycardia, because if it was a ventricular arrhythmia, we would have had wide Qrs complexes, right? So along with the narrow Qrs complex, what you realize is that we don't have an individual P or a T wave, but the P and T waves have been merged together. So just look carefully, the P and T waves have been merged together. So we have the appearance of a TP wave, right? If the T of one and the P of the next one is coming close together, they merge together, and that is the appearance of the TP wave. Along with that, you can also see a slight ST depression over here. You can see a slight ST depression. See, ST depression, ST depression, ST depression, right? This is the ST depression, ST depression. So you can also see ST depression over here. So if you have a narrow complex QRS with the TP wave and ST depression, I hope you've been able to diagnose the condition. Yes, rightly, it is atrioventricular nodal, AV nodal, reentrant tachycardia, or AVNRT. And this AVNRT is also known as PSVT, that is paroxysmal supraventricular tachycardia, paroxysmal supraventricular tachycardia. So if you look at the approach to this patient of PSVT or AVNRT, right, we could divide it mainly into two parts. What are the parts we could divide it into? Yes, we could definitely divide it into a person who is symptomatic and a person who is asymptomatic at present, a primary case, but whose ECG has revealed such a finding, right? So you could divide it accordingly. So yes, if you have an acute setting, you'll have a particular protocol, and if you have a primary case that is basically an asymptomatic patient, then you would have a different protocol altogether. So what do we basically do? In an acute setup, the approach we have for adults and children might just vary. You understand one thing, that the pathology behind a PSVT is basically a re-entry phenomenon or a circuit phenomenon. That means one wave which is entering from the atria to the ventricles through the AV node. A part of it is being recirculated via a circuit, an extra bundle, and that current is recirculating and it is exciting the ventricles prematurely as compared to another linear flow of current coming through the next impulse from the atria to the ventricles via the AV node. One impulse is coming, a part of it is going straight into the ventricles, another part of it is being recirculated via another bent pathway, and this is going in a circular motion on and on and on. And what is basically happening is, you see this one current is passing all the way. A part of it is taking a U-turn over here, and the second current is coming, but before the second current is able to reach, this one again passes back. So this one finds the AV node refractory, it is died down. Again the third one comes, till then another circuit of this loop current has gone. This one finds this refractory. So what basically happens is, the ventricles are going to contract prematurely and fast as compared to what it would be if the normal currents or impulses from the SA node were to come and excite the ventricles. So basically, the basic thing we want to do over here is we want to increase the parasympathetic tone so that this excess contractions, increased heart rate of the individual can die down. And for that, the best thing we can do is to stimulate the vagus nerve. But how do we stimulate this vagus nerve? In case of children, it is pretty easy. If we just give a facial ice pack, right, you apply a facial ice pack to the child, or you make the person or the child do a Valsalva maneuver, that means breathe against a closed glottis. All this can stimulate his vagus nerve and bring about a natural cure to his ailment. But if it is an adult, we would usually prefer a carotid sinus massage at the angle of the mandible. If it's still not responding, we would give a shot of IV adenosine. You might not know the dose, but usually it's a 6 mg or 12 mg shot, and then of course you can go in for a DC shock of around 200 joules. Usually the range is given as 120 to 200 joules. A biphasic shock can be given, right? So you can go for that. DC shock, biphasic, usually 120 to 200 joules. And if you have a primary attack, in that case you can go for oral verapamil, usually helps to control the excessive rate of the heart. And if even that is not being able to control the attacks, then for definitive management you would go for a radio ablation of this accessory bundle which has been formed. So you can go for a radio ablation, or you can even go for a catheter ablation, whatever it is. So catheter ablation. Of the bundle. Now if we look carefully at this question, Which of the following is not included as a form of treatment? So carotid sinus massage, yes, it was used. It excites the vagal receptors present out here. You know, we have the carotid body, and that basically is one of your baroreceptors. You know that you have the baroreceptors near the aortic arch, and you also have the baroreceptors here at the carotids, as a result of which when you wear a very tight tie, it might press upon that, and your baroreceptors being activated, you might just have a syncope because your heart rate, perfusion, everything drops down, right? So yes, like when you press upon the baroreceptor present over here, that gets activated, it tries to lower the blood pressure, the heart rate comes down, cardiac output falls, cerebral ischemia, anoxia, and you might get a syncope. That is what I was trying to say. Carotid sinus massage will help in reducing the excessively increased heart rate. IV adenosine, yes, shots are given. I usually told you. Biphasic DC shock, again I told you, can be given. But IV epinephrine, no, that does not have a role at all, and rather, you know, it has alpha 1 and beta 1 activity. It will rather aggravate the pathology. So that is the odd one out. And so which is the one which is not included is IV epinephrine. So all of you can see this ECG strip, and a bit of clinical touch to the question as well. A 55-year-old man presented in the ER of your hospital in an unconscious state with hypothermia. His capillary blood glucose was 100 mg per dl. His plantar was down. His DTRs, deep tendon reflexes, were normal, and the ECG is shown above. So which of the following would be the best line of management for him? 25% dextrose IV, IV levothyroxine, IV retiplase, or IV regular insulin. So basically this approach which I have tried to address over here was one of our professional final MBBS questions a couple of years back, I presume, and I really enjoyed transcripting it into sort of an MCQ, and it's important for your clinical skills as well. So if you look carefully at the ECG, can you see something abnormal? Definitely you can. What is the abnormal thing you see? This wave, this wave, this wave, this wave, this wave, right? Having this typical appearance, right? After the R wave, you have this T wave, and as you can presumably understand, it is an ST elevation. It is an ST elevation. It's a tall T, it's a tall T, and of course you have a specific name for this sort of a pattern. It is associated with a particular condition which could lead to such a patient presenting in your ER, so you need to know that, right? What are the things we are suspecting? Giving it the four options, can you play the back calculation game now? IV 25% dextrose, where do we give it? Where a person has less of glucose in his body. Can a person faint due to that? Yes. So hypoglycemic attack, hypoglycemic coma. IV levothyroxine, where do we need to give? Where the person has less of thyroxine. Can a person faint due to that? In severe mixed edema, yes, his BMR drops to a substantial rate and his CNS might stop working altogether. His neurons in the brain don't manufacture enough energy to support themselves, so IV levothyroxine might be required there. IV retiplase, thrombolysis, well, some of you might be thinking about the cardiac axis, that this person maybe had a cardiac event due to which he fainted, but the chances of it are pretty rare because in the question you've been given clues about his deep tendon reflexes and plantar. That means we were thinking about maybe a cerebrovascular accident which has led to this patient coming to your ER in an unconscious state altogether. So yes, but in cerebrovascular accidents, ECG, yes, they're definitely relevant. You can have an atrial fibrillation or other indicators of coronary malfunction over there, but we'll have to think about it. And IV regular insulin, where is it given? Yes, if it is a patient of diabetic ketoacidosis or hyperosmolar non-ketotic coma, then the person could faint. So even that sort of a person could be brought to your ER in an unconscious state. But which of them do we look out for over here? So look carefully. What are the DDs of this unconscious patient we have in front of us? The DDs of unconscious patient we can think of over here would include a diabetic ketoacidosis or a hyperosmolar non-ketotic coma, right? It could include what? Yes, mixed edema coma. It could include a hypoglycemic coma. It could include a CVA. It could include many others, but as of our MCQ over here, we would like to concentrate on these many situations. So let's read the question carefully now. It says that a person has been brought unconscious to the ER with hypothermia. So hypothermia goes positive definitely for mixed edema coma. You know, hypothyroid people have hypothermia. In DKA or honk, not really, because if you have sepsis, you might have fever. Hypoglycemia, sometimes yes, the person may develop hypothermia. So I would just maybe do a dotted plus for hypoglycemia over here, hypothermia over here. May or may not be, you never know. And CVA also, more often than not, we don't find hypothermia. His CBG was found to be 100 mg per dl. So 100 mg per dl rules out DKA or honk where you have hyperglycemia, rules out CVA as well, maybe, but we are not really sure. Rules out hypoglycemic coma, because if you have 100 mg per dl as your CBG level, you can neither say that the sugar is too high. So DKA and non-ketotic hyperosmolar coma cut out, hypoglycemic coma cut out. That's how you use the data to your advantage. It could still be either mixed edema coma or CVA, still not yet finalized. And you could see his knee jerk and plantar reflexes were normal. In a CVA, the knee jerk or the deep tendon reflex would be exaggerated and the plantar would also be upgoing. So in this case, we don't have this. In this case, we don't have this, so it is not a CVA. So possibly our answer is going in favor of, yes, mixed edema coma, where you have hypothermia, you have normal CBG, and you have normal reflexes. And in the ECG finding, you have an ST elevation, with a tall T as well, and you have a special wave on the ECG. If you could see it, it is known as the J wave or Osborne wave. J wave or Osborne wave. This is the wave we were talking about. This is the wave we were talking about. See, this wave, this tall T wave seen in cases of hypothermia, usually associated in patients of mixed edema coma or hypothyroid attacks, is known as a J wave or Osborne wave. J wave or Osborne wave. And this is particularly associated. With your hypothermic states where the body temperature is below 36, sometimes even below 32 degrees Celsius, right? So the most favorable diagnosis which we would have over here is definitely mixed edema coma. Now, what are the treatments to these different scenarios which we've discussed over here? So DKA or HONC, whatever it be, the treatment was IV fluids and IV insulin, For hypothermia, in case of mixed edema coma, the treatment would be IV levothyroxine or liothyronine. If it were due to hypoglycemia, we would have to give IV dextrose, maybe 25% dextrose. And if it were a CVA, we would have to do a CT scan first of all, non-contrast CT scan, see if it is a acute ischemic stroke or a hemorrhagic stroke. Hemorrhagic stroke, we would look to reduce the intracerebral pressure by giving osmotherapy, including drugs such as IV mannitol, or we might even have to reduce edema by giving steroids, right? But mainly, If it is an acute ischemic stroke, we go in for thrombolysis with IV retiplase. But over here, since our diagnosis is mostly centered around myxedema coma, so the treatment comes out to be IV levothyroxine. Yes, it is IV levothyroxine. So, best line of management, since we are seeing Osborne waves and the other things we've already ruled out, we've said that possibly this patient is belonging to the category of a myxedema coma. We would definitely do a T3 T4 TSH, confirm the hypothyroid state of this person, take a history from his kins if he's having medications of levothyroxine tablets or other supplements and he's missed some doses, whatever, and then if we diagnose him to be a case of hypothyroidism and suspect this to be a case of myxedema coma, we'll start off with IV levothyroxine. So friends, what are we looking at over here? We are looking at an ECG with an abnormal shape, and the question says that which of the drugs can cause the appearance of such an ECG. Look very carefully, the options are amiodarone, warfarin, digoxin, lignocaine. We studied about lignocaine in its role in suppressing the ventricular tachycardias. We've studied about amiodarone in the sense that it is also one of the drugs used in arrhythmias, von Williamson classification. It has some action on the potassium channels also, you know that. Digoxin, warfarin, well, warfarin is, as you know, it's an anticoagulant, and digoxin is used in cases of congestive heart failure along with atrial fibrillation. Which of these drugs can cause this following appearance? What is the appearance, first of all? Let's have a look. Can you look at this? I think all of you are being able to appreciate this. So, Chak De India. This looks like a hockey stick, right? A ball over the hockey stick. So, this appearance in an ECG, which basically signifies an ST depression, usually of more than 1 millimeter significantly, is called a hockey stick sign. Hockey stick sign. Right? Good. Next, what are the other effects that this particular drug, I didn't say which drug yet, can cause upon the ECG? Yes, you will see that this is the beginning of the P wave, this is the beginning of the R wave. Normally it should be 3 to 5 small squares or 120 to 200 milliseconds, right? But over here you see it as 1, 2, 3, 4, 5, 6. That means more than 5 small squares. So you have a prolonged PR interval, And talking about the QT interval, usually QT interval normally is 9 to 11 small squares, and that means 360 to 440 milliseconds. And sometimes associated with this drug use, you could find a QT shortening. So we spoke about a triad of 3 things. What are those 3 things? Firstly, you have an ST segment depression, which is your hockey stick sign. We spoke about a PR interval prolongation, and we spoke about a short QT interval, right? The triad of these 3 echocardiographic events is attributed to the use of a particular drug. I guess most of you know, digoxin. There are very many other causes of ST segment depression, as I already told you. Wherever there is a mismatch between the supply and demand of blood in the heart, apart from the fact that it can also happen in situations where the person is being made to do a treadmill test or is undergoing some physical exertion. So all these cases you might have a ST segment depression along with concurrent hypertrophy of the musculature of the left ventricle. But over here we are concerned about which drug causes this ST depression, which looks like a hockey stick. So yes, it is digoxin. So you've seen this ECG. What is this ECG all about? Yes, a ballerina dancing on the floor and her heels rubbing against the tiles, producing a pattern similar to what we see on the ECG. Any idea? A term which is not English? Yes, this is Torsades de Pointes. This is Torsades de Pointes. ECG above depicts a condition best treated by oral flecainide, oral verapamil, IV metoprolol, IV magnesium sulfate. IV metoprolol is usually a drug we used to use in cases of chronic stable angina. We don't even use IV metoprolol there, we use oral metoprolol sometimes. Anyways, yes, metoprolol is a drug we use for chronic supply-demand mismatch of the myocardium. Oral flecainide, yes, pre-excitation syndromes, WPW syndrome, LGL syndrome. Oral verapamil, you could use it in many places, especially even we spoke about oral verapamil being used in the supraventricular tachycardia's primary attacks. We use verapamil and diltiazem over there. But the answer you need to know over here is IV magnesium sulfate. Because in monomorphic ventricular tachycardia, we told you a lot about many drugs. We talked about amiodarone, we talked about primary cases being treated with your calcium channel blockers and beta blockers, but specifically for polymorphic ventricular tachycardia, IV magnesium sulfate, that is the drug you need to know. And what is most interesting, usually 1 to 2 grams or 2 to 4 grams over 30 minutes is given. That is a fact which most of you know pretty well. But where are the other instances that we give IV magnesium sulfate is something which might interest you and might be something which you need to know. So, IV magnesium sulfate can be given in the following conditions. IV magnesium sulfate definitely can be given in Torsades de Pointes, that is a CVS condition, which is your polymorphic ventricular tachycardia, It could be given in, what is that, status asthmaticus, yes. It could be given where a woman just prior to childbirth or even during childbirth is in seizures, so you could give it in, yes, eclampsia. You could definitely give it in the form of antacids. Although for antacids we would rather give magnesium oxide and magnesium hydroxide, so I would not say IV magnesium sulfate is given over there, but you definitely use magnesium compounds as antacids, and you also have magnesium compounds being used as purgatives. But IV magnesium sulfate, at least this Torsades de Pointes, status asthmaticus and eclampsia, you need to be remembering them. And yes, saturated solution of magnesium sulfate definitely used as which is cut down this IV, I could say magnesium sulfate is used as a purgative, of course, and magnesium hydroxide being used as a antacid as well. But IV magnesium sulfate, cardiovascular cause, Torsades de Pointes, respiratory cause, status asthmaticus, and CNS related cause where you have seizures and eclampsia is pretty useful. And you might also be knowing the name of the regimen which we use. Gynecology people teach you, Pritchard regimen. There are a number of other regimens as well, but this Pritchard regimen you need to know well, where you give a loading dose and a maintenance dose. Loading dose has IV and IM parts. How much, what percentage solution, all that is gynae, I am not going into that. But yes, the ECG depicts a condition, Torsades de Pointes. You can see you have narrow complex, now wide complex QRS, wide complex QRS, and some of them are not so tall, some of them are very tall. So it is polymorphic, it is not of a single type of pattern, it is not monomorphic, it is polymorphic ventricular tachycardia, and you would choose IV magnesium sulfate, 2 to 4 grams IV over 30 minutes for treatment purpose. Some books say 1 to 2 grams, but that's it. So friends, as you can see over here, this ECG strip very carefully, and we've said that all of the following may be used as treatment modalities for the condition depicted above except potassium chloride syrup. Nebulization salbutamol, IV insulin dextrose and IV calcium gluconate. Good. But first you need to diagnose the condition, right? So what will this condition be where you can see tall T waves? Tall T waves. How do you know I can call them tall T waves? Because you know they are more than 10 millimeters tall in the chest leads. It's definitely more than 10 millimeters, almost 4 large squares, and more than 5 millimeters tall in the limb leads. It's definitely more than 5 millimeters, almost 15 millimeters. You have tall tented T waves. Sometimes you might be having an accompanying ST elevation alongside very small P waves, and the T wave is rising, it's pulling up the ST along with it, the P wave is becoming short, and in the tug of war, the QRS complex is becoming wide. This is definitely more than 2 to 2.5 small squares, it's almost 10 small squares. So your wide complex QRS, even if it be only via the S, right? So tall tented T waves plus minus ST elevation, small or inverted sometimes P waves, and broad complex QRS. This together will constitute what? Yes, hyperkalemia. And so our next point of interest becomes to discuss the treatment modalities of hyperkalemia. Hyperkalemia. How do we treat hyperkalemia? Yes, you know, if this is a cell and if you have potassium outside, one molecule which will help you drive potassium back into the cell would be, yes, insulin. So if you can give around 10 units of IV regular insulin, and since that would cause hypoglycemia, so in order to combat that hypoglycemia, you can give IV 25% dextrose. So that could be one of the treatment modalities. The second modality could be a drug dealing with the adrenergic system. Beta adrenergic agonist, mainly the beta 2 adrenergic agonist, because you know the beta 2 adrenergic agonist will also be driving the potassium back into the cell. You know that the beta 2 adrenergic receptor is responsible for, yes, glycogenolysis. It will produce glucose from the stored reserves in the body, right? That's how it maintains the metabolism. You've studied about that in your biochemistry. So when it will do that, basically what will happen is the more will be the glycogenolysis and more will be the glucose levels. Body, in order to keep that glucose under control, might be producing insulin endogenously, and that will cause the potassium to enter the cells. That's how beautiful it is. So the moment you're giving beta 2 adrenergic agonists, glycogenolysis, more blood glucose, insulin comes in the picture to normalize that blood glucose, and in the process also drives the potassium back into the cell. So a nebulization with salbutamol can help your purpose. It is a short acting beta 2 adrenergic agonist. I hope you know that. And of course, potassium and calcium are sworn enemies. So if you can give IV calcium gluconate, 10%, 10 ml of that over 10 minutes, sometimes even more than 10 minutes, say 30 minutes, that would also drive your potassium back into the cell. So which one remains? I've already discussed 3 options with you: nebulization salbutamol, IV insulin dextrose, IV calcium gluconate. All can be used. In a situation where you already have excess of potassium, would you really benefit the patient by giving him potassium chloride syrup? No, you'll worsen the patient. So that is the odd one out. So all except is potassium chloride syrup. Thank you.